Welcome and good afternoon. Thank you for joining us for today's session. Good for your heart is good for your brain. I am Dr. Rafael Ortiz, Chief of Neuroendovascular Surgery and Interventional Neuroradiology for the Northwell Health Western Region and Lenox Hill Hospital. I am pleased to be joined by my colleague, Dr. Noah Rosen.
Thank you, Dr. Ortiz. It's a pleasure to be here. I'm Noah Rosen, the Program Director of Neurology and the Director of the Headache Center at Northwell. In the previous session, our Katz Institute experts presented on heart conditions and risk factors unique to women and what you can do to take care of your heart health. We'll be sharing information on the special connection between the heart and the brain. Dr. Ortiz, please start by telling us about the heart-brain connection.
Thank you, Dr. Rosen. We don't always think of the brain and heart being connected, but they are. Your heart pumps blood through the vessels to every part of your body, including your brain. If these blood vessels are damaged, it can lead to serious health conditions such as heart disease, stroke, and dementia. When speaking about the heart, a heart attack occurs when there is buildup of plaque in the vessels or a blood clot blocks blood flow to the heart. Similarly, a stroke happens when plaque buildup or a clot blocks a blood vessel in the brain or when a blood vessel in the brain bursts. A type of dementia called vascular dementia can be the result of a series of small silent strokes leading to memory loss.
Can you further explain what a stroke is? What are the different types of stroke and how do they occur?
Yes, so when we think about stroke, there are two major categories. There is what's called ischemic stroke, which is the most common type of stroke, meaning that there is a lack of blood flow to part of the brain. And then there is hemorrhagic stroke or bleeding stroke, the type of stroke in which there is a rupture of a vessel in the brain. And those are the two major categories. And obviously the symptoms could be similar. And we're going to talk a little bit later about the details of the symptoms, but people need to know there could be ischemic or hemorrhagic.
How common is stroke in women and what puts women at risk?
So when we talk specifically about women, when women are in between their 55 and 75 years old, approximately, there is a 20% chance of having a stroke, which is an elevated risk of stroke. Now, what's important to know is that 4 in 5 strokes are preventable. And when we talk specifically about women, we talk about high blood pressure. That's one of the most common risk factor for having a stroke, whether it is ischemic or hemorrhagic. So control of blood pressure is critical. And then specifically about women, there could be hormonal changes caused by birth control medications that, especially when they are taken in someone that is a smoker, there's an increased risk of a stroke, of a blockage of a vein in the brain. And these are important things to know. Women, 20% chance of having a stroke, and 4 or 5 of them, 80%, are preventable if you control blood pressure, high cholesterol, smoking.
How do you know if you or someone is having a stroke? What are the symptoms?
So when a stroke happens, there's a sudden onset of symptoms. Right away, the person develops a neurological problem. The brain is like real estate, location, location, location. And depending on the part of the brain that is being affected, that's the symptomatology that the person is going to present with. Some very common symptoms are inability to speak, slurred speech, paralysis of one side of the body, typically face, arm, and leg. So those are the common symptoms for a stroke.
What are the current treatment options for a stroke?
So right now, we are evolving in the management of stroke. Until not too long ago, The only option was to either taking a oral pill, aspirin, and hoping for the best. But right now we do have options, and that's why it's important that someone that is having a stroke calls 911 right away, and goes to the emergency room right away. What are the possible treatments of TPA? It's a clot busting drug, a medication that is given intravenously when someone is having acute stroke symptoms. And if in many strokes, that's not enough because the blockage of an artery that is large is supplying such a large territory of the brain that there's a need for another type of intervention, like an endovascular mechanical thrombectomy, a type of procedure that I perform, in which we navigate a catheter from the artery of the leg or the artery of the arm, and we go into the arteries of the body. We go into the arteries of the brain and aspirate or remove the clot with a stent. These are treatments that are not offered in every hospital, so that's why it's important to have to go to a comprehensive stroke center if possible. If not possible, definitely the different hospitals have relationships with different stroke centers, and definitely the treatment of TPA can be given in any hospital of the clot busting drug. But then if there's a need for an intervention, the person can be transferred over to a comprehensive stroke center. Now, that's for the type that is the blockage. For the bleeding type of stroke, there are treatments as well. Most of them are caused by high blood pressure, and that's just medical management. But others might need a craniectomy to relieve some pressure from the head, might need an endovascular procedure to treat a brain aneurysm or a brain AVM, an abnormal connection between artery and vein that shouldn't exist. But again, depending on the stroke type, that's how we tailor the treatment.
During a stroke, every minute counts, and quick action can lessen brain damage that can be caused by a stroke. How can we easily remember the signs of a stroke?
Yeah, so there's a mnemonic: be fast, BE space FAST, be fast. Obviously, this is an easy word or phrase to remember, because we need to act fast when a stroke is happening. Every second counts. Every second that there's a blockage of an artery in the brain, millions of neurons are dying. So the person has to call 911 right away, or their family members need to call 911 right away to go to the hospital. And B fast stands for the B, balance, loss of balance. The E, eyes. Some people get loss of vision and or double vision. F for face drooping, A for arm weakness, S for speech difficulty, and T, time to call 911. Be fast. So, Dr. Rosen, to change the topic a little bit, what can you tell us about the link between migraines and heart disease?
So our understanding of this has evolved over many years. Initially, we had seen some association with things like palpitations and low blood pressure, but now we've started to see through other studies, other associations. About 20 years or so ago, they found an association with a high rate of holes in the heart, what's called a patent foramen ovale, and actually several other vascular abnormalities. Although closing those don't seem to help so much, it suggested there is some association there. And in the last 10 years or so, we've learned that women with migraine, particularly migraine with aura, are at a higher risk of both stroke and heart disease, although that's not a modifiable risk. It's a lot like family history of heart disease. So even though there's an association, it may not be a causative association. And we continue to learn more as more and more research gets done in this area.
Great. And Dr. Rosen, is there a difference between a migraine and a headache? Because sometimes it could be confusing to people.
Yeah, so a headache is really a generic term. And when you look at headache in the population, over 94% of the population will have had a headache at some point. Migraine is different. It is the most common of the severe headaches, and it affects about 12% of the population. So that's about 47 million people in America alone. And the diagnosis of migraine, well, you need several repeated events for this. Not that anybody needs an event, but to make the diagnosis. And generally, you need two from column A and one from column B. So column A is one-sided headache. That's actually where the word migraine comes from, is hemicrania, or half of the head. Throbbing or pulsing in quality, moderate to severe in intensity, and worsening with movement. And then either sensitivity to light and loud noise or nausea. So oftentimes people just think of migraine as a bad headache, but there's a lot of other very specific features that one has to have to actually meet that criteria.
And I know that migraines can be very complex, but what causes migraines, and why is it more common in women?
Well, it's a very interesting question. As I mentioned before, about 12% of the population will have migraine. That seems to be about 18% of women and 6% of men. So it's about 3-to-1 more common amongst women. But when you look within a family, if somebody has migraine, there's a 70% chance that you'll have a first-degree relative who also has migraine. So that really speaks to a genetic underpinning for the condition, although the frequency, severity, even response to treatment can be very individual. We're still not clear on why it's more common in women than in men. It's actually about equal until menarche, until menstruation occurs. So part of the difference may be hormonal changes as a trigger for these events, but it also may include things like complex inheritance, like mitochondrial disease, which is inherited strictly through the mother as well. So there's still a lot more that we need to know, but the prevalence of the condition is clearly much more so in women and affects them dominantly, and especially during from the teen years till the mid 40s, where the peak prevalence is.
Great. And what are the available treatments for migraines?
So when we think of treatment, often we'll think of both acute treatments and also preventive or prophylactic treatments. That is something to use as needed when an event occurs and something to avoid events. And these can be either pharmacologic or non-pharmacologic. There's a lot more research that goes into the pharmacologic care, but many people are interested in other non-pharmacologic treatments as well. So some of these are specific, that is specific to migraine. Others may be more generalized treatments for pain conditions in general. And that's both pharmacologically and non-pharmacologically. So talking about non-pharmacologic management, that can include things like trigger identification, improving sleep, regulating diet. Those things help raise the threshold that it takes to trigger off an event. And then other non-pharmacologic acute treatments can include things like sleep, rest or relaxation, showers, cold applied to the head, massage. But then there's also a pharmacologic option. So acute pharmacologic treatments include over-the-counter remedies, like ibuprofen or combinations like Excedrin, and also prescriptive medications. The triptan medications came out in the 1990s. And more recently, we have specific treatments called CGRP antagonists that you may see plenty of commercials on as well. Preventively is similar, that there have been older treatments that were non-specific. And the last few years have seen more and more specific treatments come out that target CGRP in particular. So our options continue to grow.
Are migraines a risk factor for other brain disorders such as Alzheimer's and dementia?
Well, migraines not clearly associated with dementia or other degenerative conditions, but there are many other conditions that are comorbid with migraine, that is, occur together. Things like essential tremor or rare types of inherited seizures or anxiety or depression. So there are a lot of co-occurrent conditions, but it's not a degenerative condition. Even though it may feel like brain cells are dying with each attack, that's not what's actually happening.
And when I see people that have had strokes in the past and or have had a bleeding type of stroke from an aneurysm rupture or from other types of bleeding in the head, in the brain, they commonly complain of headaches for acutely, number one, when they're having the symptoms, and then thereafter for weeks, months, sometimes years after the symptoms. How do you manage these type of patients? Because are these types of migraine? Yes, no, and if not, how do you manage them? Should the person be afraid that they're going to have another type of bleeding because they continue to have these recurrent headaches? How can you counsel these people?
It's an excellent question. The International Headache Classification breaks headache disorders into two types, into secondary headaches, where the headache is secondary to another condition, and primary headache disorders, where the head pain is the primary issue. So primary disorders include things like tension type headaches, migraine, or cluster headaches. Secondary headaches include ones from tumors, from strokes or aneurysms, from traumatic brain injury. So in those cases, we can more clearly identify what the cause is. And that sometimes helps us, first off, to treat the underlying cause, particularly if it's a progressive headache or one that occurs like a thunderclap, which is a major warning for a headache associated with a blood vessel abnormality. And it also gives us some guidance in things that we want to avoid. For example, using aspirin in somebody that may have had a hemorrhage already in the past. So again, primary headaches are very common, secondary headaches much less so. And it's important that we assess the history there as well. You know, are the headaches that we're having similar to what have occurred in the past, or have they changed? If they've changed in their quality or associated features, that may require more investigation versus one which has a stereotype pattern over time, more consistent with a condition like migraine.
Yes, and it's important to mention also, not every stroke is associated with a headache. The bleeding type of stroke is the one that is more commonly associated with pain, with headache. Whenever there's a blockage, typically that's the person doesn't feel pain, which is different from a heart attack, and that's why when people are having chest pain, it's very easy to go to the hospital right away because it's uncomfortable. But the stroke, if it's the type of not getting enough blood flow to part of the brain, the person might not feel any pain at all. And they might have paralysis or weakness or decreased sensation on part of their body. And instead of waiting for that sensation to come back or for that speech to get better, the person needs to go to the hospital for emergency treatment. For the types of bleeding stroke that does present with headache, a, one of the types of stroke that we deal with is an aneurysm rupture, like Dr. Rosen mentioned, the thunderclap, severe, all of a sudden severe headache, the worst headache of your life. That's how people describe it. And when that happens, again, it's an urgency. The person needs treatment for that aneurysm right away. 33% of people that have bleeding from a brain aneurysm die from that bleeding. So if someone survives, it's important to treat right away to prevent another rupture from happening. And since we're talking here about the heart-brain connection, this type of bleeding called subarachnoid hemorrhage also affects different parts of the body, lungs, kidneys, but one that is very, very important is it can affect the heart. Some people can present to the hospital simulating as if they're having a heart attack because on top of the headache that they're experiencing from the bleeding from the aneurysm, and they can have a stunned myocardium, that the heart doesn't work as it should. And it can present with abnormalities in EKGs, in abnormalities in the enzymes of the heart. And obviously, when we treat these patients, we treat them together with the critical care specialists, with the cardiologist, and the rest of the team. So as we can see, there is a clear connection between the brain and the heart. And it's important to take steps to keep both your heart and brain healthy. Adopting healthy lifestyle behaviors can reduce your risk of stroke and heart disease by as much as 80 and 90% respectively. Dr. Rosen, what are some simple steps that women can take now?
Well, as I mentioned before, prevention or prophylactic treatment is extremely important. Making healthy food choices is a good place to start. Hydrating well is extremely important and unfortunately not done as well or often as it should be. Regular meals, you will rarely find studied or established diets that tell you to skip meals because of the risk of on glucose tolerance. And actually, high omega-3, low omega-6 diets. Recently, in the headache world, they did a study that did show that 2 fish meals a week can play a role with reducing migraine frequency. And that actually shouldn't come as a surprise because the American Alzheimer's Association and the American Heart Association have also pushed for at least 2 fish meals a week to reduce risk. Adding more movement to your day is also a key issue. In migraine, there's been a study also in the last year that again said at least half an hour a day, 5 days a week of moderate aerobic activity had a preventive and prophylactic effect. And we know that has a profound effect as well upon blood pressure, upon mood, upon plenty of other aspects of the person. Managing stress, again, not just when you're under stress. I have yet to see the medical issue that stress makes better. And oftentimes it also needs to be thought of preventively, building things into your life to help reduce that stress load so you can bleed it off a little bit on a regular basis. Getting enough sleep, another thing that's quite important and quite difficult for people to establish. It's good to remember that quality sleep is the amount of time times the quality of sleep itself. That is, you need to give enough. And if you do have an issue like snoring or sleep apnea, those need to be addressed separately as well.
I will also add, it's critical to have an active lifestyle. Physical activity does help to maintain a healthy weight, to reduce the other risk factors that accompany obesity, and could potentially lead to strokes and heart attacks. So maintaining an active lifestyle, exercising, maintaining a healthy weight, eating correctly, eating healthy, um, um, in order to decrease obesity, in order to decrease the incidence of diabetes, in order to decrease the incidence of high cholesterol and high blood pressure, because all of those can lead to stroke and heart attacks. And when I say eating healthy, I mean, like you mentioned, healthier vegetables, healthier uh, uh, um, uh, fish instead of red meat, turkey instead of chicken, um, grilled instead of fried food. So those are specific things that we can all do for a better, healthy lifestyle. Keep your brain active, maintain social connections. These are all critical so that we, as we age, we maintain a healthy lifestyle, limit alcohol and avoid risky substances. If you smoke or use other tobacco products, quit now.
We want to thank everyone for joining us today. We hope you found this session informative, and please remember to partner with your healthcare provider for any additional questions and information about today's topic. Thank you again.
Thank you.